Alright, now this is my jam. Welcome to the section on psychiatric emergencies, the primer that every doctor needs to know about medical emergencies that can happen to psychiatric patients. And I know, psychiatry may not be everyone's jam, but with 1 in about 5 Americans taking some kind of psych med, recognizing emergent complications from psych meds and the interactions between them and other drugs should be standard issue for every physician who treats patients. And there's no more illustrative case for this than the case of Libby Zion, a young woman whose death changed the medical legal climate and residency regulations for decades to come. Libby Zion, a young woman known to be taking an MAO inhibitor for depression, was seen in the emergency department of a New York hospital for fevers, chills, and increasing agitation. And of note, she developed these spastic jerking motions. Nobody had any idea what was going on, so they admitted her for observation. They gave her IV fluids, and they gave her Demerol, otherwise known as meperidine. When she became more agitated, they put her in restraints and used haloperidol to sedate her even further. Probably a lot of you know how this story ends. While the haloperidol did sedate her, she also became profoundly hyperthermic, to the point that, by the time anyone noticed, her temperature had reached 107 degrees. And despite aggressive attempts to get her cooled down, Libby Zion eventually went into cardiac arrest and died. Now, there's a lot of dimensions to this case, not the least of which is that there's some suspicion that besides the phenelzine, meperidine, and haloperidol in her system, there may also have been cocaine on board when she first came in. But the reason I bring this up is that at the time of the case, even though the residents took most of the heat for this and were actually tried for murder, as ridiculous as that sounds, a lot of New York physicians at the top of their field actually came and testified that they would have been just as stumped by the case as the residents were. Because the most likely diagnosis, serotonin syndrome, is a pretty uncommon but life-threatening consequence of mixing multiple serotonergic drugs, and at the time of the trial, it was considered about as arcane a zebra as you could get. Fast forward 30 years where Libby Zion and serotonin syndrome are almost household names and it seems like everyone's on psych meds, there's really no good excuse for missing this diagnosis anymore. So without further ado, let's talk psych emergencies. There's a cluster of psych medication-related disorders that all present in a pretty similar fashion, and you should know how to distinguish between them for step 1. Because neuroleptic malignant syndrome is probably the best studied, it's got the best mnemonic associated with it. Everyone knows and loves the fever mnemonic. Remember what it stands for? It stands for fever, encephalopathy, more specifically agitated delirium, vitals unstable, otherwise known as autonomic dysregulation or dysautonomia, enzymes, meaning elevated CPK, and rigidity. Just take a moment to burn that list into your brain and remember that fever specifically pertains to neuroleptic malignant syndrome, the disorder specifically associated with the antipsychotics, specifically the typical antipsychotics. I'm trying to make sure you rely as little as possible on brute force memorizing, by the way. Instead, you should learn the patterns and distinctions that'll get you the correct answers on the test. Serotonin syndrome, the diagnosis that was posthumously given to Libby Zion, is characterized by a lot of the same stuff. You get fever, a very similar kind of agitated delirium, and dysautonomia. You can get rhabdomyolysis from the fever, but you don't tend to see it to the same degree, because the biggest difference between the two is that while NMS causes rigidity with excessive muscle contraction, serotonin syndrome is characterized by motor hyperactivity. Now, this can range from subjective psychomotor agitation to the type of spastic jerking motions that Libby Zion had. But the defining feature, and really what separates serotonin syndrome from all of the others on this page, is the more tangible signs of hyperreflexia and clonus on examination. While NMS is caused by a pretty narrow range of drugs, serotonin syndrome can be caused by any serotonergic drug. It's classically caused by simultaneous administration of 2 or more serotonergic agents, but even a high dose of one drug can do it. So, when you think of serotonin activity, what class of medication typically comes to mind? While pretty much every single class of antidepressant has serotonergic activity, the MAOIs are particularly associated with serotonin syndrome. It is worth noting that St. John's wort, a nutraceutical antidepressant, actually does have real serotonergic properties and can cause serotonin syndrome. Every single stimulant drug, amphetamine, ecstasy, meth, Adderall, and cocaine can precipitate serotonin syndrome as well. If Libby Zion was using cocaine that night, then this certainly might have contributed to the serotonin overload along with her MAOIs. A few of the synthetic opioids, including the now famous meperidine, but also the commonly used fentanyl and tramadol, can precipitate serotonin syndrome as well. Obviously, the migraine-specific meds like the triptans and ergots are serotonergic. They're literally direct serotonin agonists. And finally, there's some of our most commonly used antiemetics like ondansetron and metoclopramide. Look, this is going to get painful in just a sec, so hear me out. These are just some of the categories of potentially serotonergic medications, but these cover the most important ones. Just read the book for the rest of the weird ones like linezolid, and remember that serotonin syndrome usually happens pretty soon after the serotonergic meds get increased, whereas you can actually get neuroleptic malignant syndrome days to weeks after starting the meds. Malignant hyperthermia is caused by anesthetic gases and the paralytic agent succinylcholine that's generally used before you intubate someone, so this is really more in the domain of anesthesia than psych. This isn't really a dose-related thing. In general, the only requirement is that you have to have a certain mutant phenotype of the ryanodine receptor on skeletal muscle that just doesn't play nicely with anesthetics. While serotonin syndrome and NMS are primarily driven by disruption of autonomic regulation of the central nervous system, malignant hyperthermia is primarily driven by the aggressively rigid muscle contractions that cause both hyperthermia and rhabdomyolysis. Agitated delirium, which is kind of a central effect, isn't really a part of this phenomenon, especially since you're usually under anesthesia when it happens. But I'm going to guess that if you wake up with a temperature of 108 because nobody realized you were having malignant hyperthermia, you'll probably be at least a little delirious. And your vitals will usually be abnormal, but not in the same crazy labile way that you see with NMS and serotonin syndrome. You'll be tachycardic because of the fever, and as your ruptured muscle cells continue to release potassium, the hyperkalemia could eventually put you into cardiac arrest. Finally, we have anticholinergic and sympathomimetic toxicity, and even though this isn't in the section on first aid, it's important to contrast these with serotonin syndrome because they can look pretty similar, and they're a heck of a lot more common than any of these final three. Remember, in anticholinergic toxicity, you get hot as a hare, red as a beet, mad as a hatter. The vitals definitely aren't normal, but they follow a pretty predictable pattern of tachycardia and hypertension, unlike NMS and serotonin syndrome. And like serotonin syndrome, you can get rhabdomyolysis, but it's not usually to the same extent as NMS or malignant hyperthermia since there's no muscle rigidity. Sympathomimetic toxicity shares a lot of these same features, which makes sense, since blocking the parasympathetic nervous system does almost the same thing as activating the sympathetic nervous system. And neither of them causes the same kind of reproducible hyperreflexia and clonus that serotonin syndrome does. So, how do you tell anticholinergic toxicity and sympathomimetic toxicity apart? The answer is that with anticholinergics you get dry as a bone, which is not something that you see with any other disorder on this page. Every other one of these disorders is going to make you sweat. The combination of fever and lack of sweating is something that's very specific to anticholinergic toxicity, and if you want to test this, the armpit is one of the best places to check, even though it's a little gross. Because almost everybody has at least a touch of baseline sweat in their armpits at all times. Or maybe that's just me. Shut up. The treatment of these conditions is where Step 1 medicine and real-world medicine actually differ quite a lot. Step 1 focuses on trivia because it's easy to test. Each of these syndromes supposedly has an antidote that fixes everything. Dantrolene for the muscle rigidity in both malignant hyperthermia and NMS, the dopaminergics bromocriptine and cabergoline for the central effects of NMS, the serotonin antagonist ciproheptadine for serotonin syndrome, the cholinesterase inhibitor physostigmine for anticholinergic toxicity, and just plain old benzos for the sympathomimetics who really just need to chill out for a bit. Knowing which antidote to give in which conditions is high yield for Step 1, but the truth is a lot less sexy. In real life, you're not going to be whipping out these arcane diagnoses and then giving the magic drug that saves Libby Zion's life like Dr. House. Of all of these, only dantrolene has a significant effect on reversing malignant hyperthermia. If you're going to get a patient to survive any of these lethal conditions, the solution is to get as good a history as you can so you have some idea of what drug is causing the problem. Discontinue the medication and don't give them any other stuff that's going to make it worse. Then, provide good supportive care to get them through their period of critical illness. Because if they survive it, they will get better. Give them antipyretics and actively cool them if the thermometer starts creeping towards 104, 105 so that their rhabdo doesn't get worse and they don't have a seizure. Keep them from hurting themselves, sedate them, or even intubate them if you have to. Give them tons of fluids so that their kidneys don't shut down from the rhabdo. And monitor their blood pressure invasively if it's all over the place by using an arterial line, and titrate your vasoactive medications to raise or lower their blood pressure as needed. Unlike the last set of psych emergencies, delirium tremens is a syndrome that's caused by not ingesting something, alcohol in this case. Delirium tremens, or DTs, are the lethal syndrome associated with alcohol withdrawal, and it's probably the oldest psychiatric emergency around, so we have a pretty good understanding of how it works. DTs is another clinical syndrome that's actually pretty similar to serotonin syndrome, just to make your life difficult. It's another central process that completely kicks your autonomic nervous system's butt and throws you into an agitated delirium. But once again, while DTs is often characterized by motor findings like tremors, the thing that's always going to distinguish serotonin syndrome from any of the other similar syndromes is hyperreflexia and clonus on exam. While DTs are strongly associated with nausea and vomiting, serotonin syndrome is strongly associated with diarrhea and hyperactive bowel sounds. And for this, you can think of carcinoid syndrome, which is another serotonergic pathology that also makes you poop your brains out. Finally, while serotonin syndrome can definitely lead to seizures, especially if you let them get hyperthermic, DTs are much more strongly associated with seizures. But more than anything, the thing that's going to tell you you're dealing with delirium tremens is the history of alcohol abuse and the unique time course withdrawal starting from the last drink. With serotonin syndrome, a lot of these patients have no idea why they're starting to feel crummy or why they're starting to get confused. And the patient may present with altered mental status so severe that they can't really give you a history when they arrive. So you have no idea what medications they're taking. Alcoholic patients generally know what's going on if they're going to have delirium tremens. They usually have fair warning before the full force of the DTs hit them because the milder symptoms of alcohol withdrawal, the shakes, the headache, the vomiting, the sweating, are seriously unpleasant, so they're gonna let you know if they're in alcohol withdrawal. And these generally kick in well before a patient goes into true delirium tremens, which almost never start before 48 hours after a last drink, and generally peak around days 3 to 5. For the purposes of step 1, there's a couple more serious alcohol withdrawal pathologies that are often confused for DTs, but aren't. Alcoholic hallucinosis sounds kind of like DTs, but there's a huge difference between hallucinations and true delirium. A person with alcoholic hallucinosis is generally going to be lucid, just with visual and tactile hallucinations. They'll be the ones coming in a day after the last drink going, "Dude, I need help, I keep seeing mice crawling around in the corners." Whereas the people with DTs are just going to be screaming incoherently at you. These syndromes can be seen as early as hour 6, and assuming a person doesn't go into DTs, will start to get better around the 48-hour mark. And as always, a good rule of thumb is that if it's been less than 48 hours, it's not really DTs, it's probably alcoholic hallucinosis. Finally, another common misconception is that if a patient has seizures, they're automatically in DTs. And that's not true, because you can have seizures as early as a few hours after your last drink. That being said, having seizures is a pretty bad sign. About a third of patients who get seizures within the first 48 hours will go on to have true DTs, so you need to treat these patients with some caution. These aren't the ones you're going to hand some Librium to and kick out the door. Now, delirium tremens, like serotonin syndrome, can be lethal as a result of the autonomic instability that leads to lethal arrhythmias and cardiac arrest. But these patients also have a greater risk of seizures and resulting airway compromise, dehydration and electrolyte abnormalities from vomiting and sweating profusely, and just straight up tend to have worse protoplasm in general as a result of the hepatic, cardiovascular, and nutritional consequences of chronic alcohol abuse. So these guys need to be treated, and treated aggressively. Benzodiazepines hit the GABA receptor in place of alcohol, and these patients who are chronic alcohol abusers tend to need a lot of GABAergic stimulation, sometimes over what would constitute a lethal dose in benzo or alcohol-naive individuals. It doesn't matter. These are legitimately sick individuals whose GABA receptors have been so fried by years of desensitization that they will literally die without that constant stimulation. So don't make a rookie ICU mistake with delirium tremens patients. Don't give patients a fixed dose based on what you think they should or shouldn't need. This kind of goes beyond the scope of what step 1 will ask you, but the standard of care is to reassess patients every hour using a scale like RASS or CIWA, and just keep giving them benzos until you reach the appropriate level of response. If a patient is acutely decompensating, you may need to redose the patient every 5 to 10 minutes. That's okay. You can give them all the benzos. Their receptors are used to it. Since Lubixion and a string of well-publicized but uncommon drug reactions, the MAOIs were the persona non grata of the antidepressants for a long time. Only recently there's been a spark of renewed interest in them for refractory cases. But if you had to ask me what the most dangerous antidepressants were, that's actually an easy one. The tricyclic antidepressants are a group of molecules that kind of look like a bouquet of flowers, and they are in fact as beautiful as they are deadly. Not only do they have a variety of ways they can kill you in as little as a week's supply of an antidepressant. And this may be crazy, but if people with depression run a high risk of wanting to commit suicide, maybe it's not a good idea to prescribe a month's worth of an antidepressant that can pretty easily grant them that wish. Nah, that makes too much sense. So how do TCAs do their dirty work? The therapeutic effect of TCAs is to block the reuptake of serotonin and norepinephrine at the presynaptic membrane, increasing the concentration of the two neurotransmitters in the synapse. And that doesn't sound so bad on the surface. It's pretty much the same thing that SNRIs do. The problem is, the tricyclics are promiscuous. They're able to bind to a number of other receptors besides the ones that cause their effects as antidepressants, and that's how they cause their mischief. TCAs perform reuptake blockade at not only serotonin and norepinephrine, but they also perform receptor blockade at cardiac voltage-gated sodium channels, the GABA receptors in the CNS, and what are affectionately referred to as the HAM receptors, which stand for histamine 1, alpha-1 adrenergic, and muscarinic acetylcholinergic. The HAM side effects, you see them pretty early on. The antihistamines are what make TCAs so sedating, and at high doses lead to coma or even respiratory depression. But that's pretty uncommon, mostly because the other stuff will kill you first. Alpha blockade causes hypotension from vasodilation, and this is actually a huge contributor to TCA mortality. The anticholinergic effects are mostly just annoying, like urinary retention, and they aren't strong enough to cause a ton of issues, so I'm not even going to go over those. The main problems are with the GABA and the voltage-gated sodium channel blockade. Now remember, we just talked a lot about GABA in the context of alcohol withdrawal. Essentially, blocking the GABA receptors greatly lowers the seizure threshold, predisposing patients to convulsions. Pro tip: because the mechanism is GABA blockade, using benzodiazepines to treat the seizures can outcompete the TCAs, so that's still first line. If benzos don't work, what you should absolutely not do is switch to phenytoin. The reason is, phenytoin, like TCAs, acts as a sodium channel blocker at the cardiac myocytes, specifically like a class 1A antiarrhythmic. And this is the final effect of TCAs that makes them pretty dangerous, completing the famous trifecta of coma, convulsions, and cardiotoxicity. All you cardiology studs, what effects do class 1A sodium channel blockers have on EKGs? Well, at the risk of sounding like a nerd, which I am, class 1As slow the depolarization of cardiac myocytes, which reliably prolongs the QRS complex. And in fact, this is one of the best clues that the rando who just had a seizure in your ER might be having TCA toxicity. But there's also a significant prolongation of repolarization through a different mechanism, and this leads to prolongation of the QT interval. When you combine early cardiac sodium channel blockade with peripheral vasodilation from alpha blockade, you're setting yourself up for some serious hemodynamic decompensation. And independently, TCA's effects on the myocardial action potential can directly cause degeneration of the EKG into VTAC, torsade de pointe, and VFib. Now, the cardiac toxicity in particular can be treated pretty effectively with a very simple agent, sodium bicarbonate. The mechanism is described a bit better in the section on TCAs, but this not only reverses the sodium channel blockade, it also allows the heart to compensate pretty effectively for the vasodilation caused by alpha blockade. If that's not enough, you can always treat the alpha blockade with vasopressors like norepinephrine or phenylephrine. And lastly, a few others that didn't fit nicely into one category or another and weren't important enough to get their own page. The legendary hypertensive crisis attributed to MAOIs is yet another reason psychiatrists generally use any excuse not to prescribe these medications. Basically, some of the foods we eat, wine and aged cheese for example, incorporate an amino acid called tyramine into their proteins. And weirdly enough, our body recognizes that amino acid as a neurotransmitter, a monoamine similar to serotonin or dopamine. And while our GI tract is generally great at breaking down proteins so they don't retain their former activity, tyramine is just a single amino acid, and so it can't be broken down any further by digestive enzymes. What normally happens is, the monoamine oxidase in our intestinal cells deactivates the tyramine before it hits the bloodstream. But if you're taking monoamine oxidase inhibitors for depression, well, I think you can all see where I'm going with this. Intestinal MAO inhibition leads to absorption of dietary tyramine, where it insinuates itself into your synapses and causes transient but often severe hypertension. Obviously, the severity of the hypertension is related to how much cheese you ate, which, in my case, would be all the cheese. But you know how hypertensive emergencies really aren't a huge deal because if a person has chronic, poorly treated hypertension, their organs and their blood vessels are used to it. Well, as it turns out, the physiology of a tyramine crisis is a lot more like the physiology of a pheochromocytoma than a hypertensive urgency. For the most part, you're taking people with otherwise normal, non-sclerosed blood vessels, and all of a sudden you're just turning the volume up on the sympathetic nervous system to 11. And yeah, your body's not going to be prepared for that. Not only does it cause splitting headaches and dizziness, but the sudden overload to the end organs is a lot more likely to result in symptomatic hypertensive emergencies, like acute heart failure, pulmonary edema, hypertensive encephalopathy, acute kidney injury, and even intracranial hemorrhages and vascular dissections. And as it turns out, the treatment is a lot like the treatment for a pheochromocytoma. Use phentolamine to control the episode, which should last until the tyramine clears from the circulation in about 6 hours, and then tell the patient to stop eating so much cheese. Acute dystonia is a reaction to the anti-dopaminergic drugs, even normal doses of them, that causes sudden, uncontrollable, sustained muscle spasm. I've actually seen this a couple times before in the ER. It's pretty alarming. Imagine you're a patient who's already psychotic at baseline, and all of a sudden, an invisible hand twists your neck to the side, grabs your eyeballs, and pulls them up towards the ceiling, and you literally can't do anything about it. I would literally never sleep again. And even though this guy down here looks like he's altered, these patients are very much lucid and are usually freaking out and in quite a bit of pain. The key to treating these is 1. Recognizing the symptoms, and 2. Knowing what causes it. Antipsychotics are the most common, but remember that other antidopaminergics are used as antiemetics, and that your favorite metoclopramide, prochlorperazine, and droperidol can all cause dystonic reactions. But since it's an extrapyramidal symptom, the typical antipsychotics generally have the highest rate of dystonic reactions. So keep that in mind before you use Haldol to sedate a patient. The most common types of muscle spasm are torticollis, which the patient in the picture is demonstrating nicely, and oculogyric crisis, which is a bit of a dramatic thing to call it because it's not dangerous. Your eyes are just forced upwards. The dangerous one that really necessitates treatment is laryngospasm, and this is actually acutely airway compromising. Patient can die in minutes from this, and I don't know about you, but I'm not particularly looking forward to intubating a guy whose neck is forcefully twisted and whose mouth and vocal cords are clamped down. Fortunately, the treatment is really simple and available everywhere. Since it's an extrapyramidal symptom, what do you treat it with? Since extrapyramidal symptoms come from lack of dopamine in relation to acetylcholine in the basal ganglia, the treatment involves lowering acetylcholine to match the level of dopamine using either a specific anticholinergic like benztropine or everyone's favorite allergy med, diphenhydramine, which is also a pretty great anticholinergic. Lithium is one of those drugs that's so old school that you can hardly believe it's around. I mean, it's not even a molecule, it's a freaking atom. And not even a very complicated atom. It's got 3 protons and 3 electrons. Seriously, the only way you could get more for less is if you told me that huffing helium was the cure for cancer, which would only be true if laughter was the best medicine. What was I talking about? Sorry, lithium. Anyway, it turns out that it's still the best drug we've got for bipolar disorder, even though its therapeutic window is absolutely horrible. That is to say that 2 to 3 times the therapeutic serum level is actually toxic, which means that lithium toxicity is depressingly common. You can check out the section on lithium in the psych pharmacology for common side effects that develop chronically, but in acute lithium poisoning looks a lot different. In acute lithium overdose, CNS symptoms predominate, and you'll see a pretty dramatic picture of confusion, nausea, vomiting, slurred speech, wobbly gait, and eventually seizures. This isn't the kind of agitated delirium you see with serotonin syndrome. With lithium toxicity, it's more like you're drunk and sloppy instead of freaking out and hitting people. It does, however, share the feature of hyperreflexia with serotonin syndrome, along with the other signs of neuromuscular hyperactivity. So you do have to watch out for that, especially if you have a patient who's on both lithium and an antidepressant. But lithium's signature move is to go for the kidneys, and this is probably the most unique thing about its toxidrome. Lithium causes acute kidney failure and overdose, and specifically causes nephrogenic diabetes insipidus. And this can be a huge problem because lithium is renally excreted, and acute kidney injury decreases the likelihood that lithium will be cleared. Supportive therapy is to hydrate and monitor chemistries closely, but if a patient's really sick or not responding to therapy, then you need dialysis to remove the lithium from the blood because their lithiated kidneys aren't going to do the trick.